Now let us continue with the lab diagnosis of Haemophilus influenzae infections. Specimen collection and transport depending upon the site of infection. Various specimens may be collected such as CSF, blood, sputum, pus, aspirate from joints, middle ear or sinuses. As Haemophilus influenzae is highly sensitive to low temperature, the specimen for culture should never be refrigerated. The specimen should be transported to the laboratory without any delay and processed immediately. Direct detection, gram staining of CSF and other specimen shows pleomorphic gram-negative cocobacilli. Capsule detection, Quelling's reaction, capsular swelling occurs when a drop of CSF is mixed with type B antiserum and methylene blue and observed under the microscope. Antigen detection, the type B capsular antigen can be detected in CSF, urine and other body fluids by latex agglutination test using latex particles coated with antibody to type B antigen or direct immunofluorescence test or ELISA. Okay. Now, in this is a satellitism of the Haemophilus influenzae. This Staph aureus streak line. This provides the factor 10 and 5. So there is progressive decrease in the size of Haemophilus influenzae colonies as we grow from the uh, Staph aureus streak line towards the periphery. Okay, the culture Haemophilus influenzae is highly fastidious, requires two accessory growth factors 10 and 5 in blood for their growth. Factor 10 is hemine present freely in blood. Factor 5 is nicotinamide adenine dinucleotide NAD, which is present inside RBCs. It is also produced by some bacteria such as Staphylococcus aureus. The growth of H. influenzae may vary in different media depending upon the availability of 10 and 5 factors. No growth on vasal media, nutrient agar and peptone water lack 10 and 5 factors, therefore they do not support the growth of Haemophilus influenzae. Growth on is scanty on blood agar. It is because only factor 10 is available freely in blood agar and factor 5 is largely intracellular, present only inside the RBCs. It is available in very minute quantities freely in the medium. Grows well on chocolate agar. While preparing the chocolate agar, blood is poured into the molten agar at 75 degrees Celsius with lysis RBCs, releasing excess of the factor 5. Hence, it supports the growth of Haemophilus influenzae. Grows well on blood agar with Staph aureus streak line. Colonies of H. influenzae grow adjacent to Staph aureus streak line, a phenomena called as satellitism. Satellitism, H. influenza can grow on blood agar if the source of fifth factor is provided. Staph aureus is streaked across a blood agar plate perpendicular to the Haemophilus influenzae streak line. Factor 5 is released from Staph aureus. Therefore, it forms larger colonies adjacent to the Staph aureus streak line and size of the colony decreases gradually away from the Staph aureus streak line. This phenomenon is called as satellitism, a property that is routinely employed for isolation of H. influenzae. Special media such as field days agar or Lewinthal's agar containing factor 10 and 5, Haemophilus selective medium containing bacteriacin and sucrose is useful for sputum specimen. In these figures A to D, we can see gram stain smear showing pleomorphic gram-negative bacilli in A. In figure B, we can see the satellitism of Haemophilus influenzae around Staph aureus streak line. In figure C, we can see the colonies of Haemophilus influenzae on chocolate agar, and D shows colony smear showing pleomorphic gram-negative bacilli. It is largely aerobic and growth is poor anaerobically. Culture plates are incubated at 37 degrees Celsius in candle jar. Growth is enhanced by 5 to 10% CO2. Culture smear and motility testing. Gram staining of culture isolates reveals pleomorphic gram-negative bacilli and hanging drop reveals non-motile bacilli. Biochemical test. Catalase positive and oxygen is positive. This test for 10 and 5 requirement. Haemophilus species vary in their 10 and 5 requirement. This property can be exploited for speciation by inoculating the isolate onto medium lacking 10 and 5 factors and then placing the 10, 5 and combined 10, 5 disc on the medium for demonstrating the growth of requirements. Growth surrounding 10 and 10 5 disc only produced by species that require 10 factor but not 5 factor. Examples include Haemophilus duceri and Aggregatobacter aphrophilus. Growth surrounding 5 and 10 5 disc only produced by species that require 10 factor but not 5 factor. 5 factor but not 10 factor. Examples include Haemophilus parainfluenzae, Haemophilus parahemolyticus and Aggregatobacter paraaprophyllus. Growth surrounding combined 10 V6 discs only produced by species that require both 10 and 5 factors. Examples include Haemophilus influenzae, Haemophilus aegypticus and Haemophilus hemolyticus. Typing method: biotyping. Strains of Haemophilus influenzae is typed based on biochemical properties into 8 biotypes, 1 to 8. Most of the clinical isolates belong to type 1, 2, and 3. Majority of invasive type B strains belong to biotype 1. Serotyping: it is carried out by using type specific antisera. Molecular method: multiplex PCR useful for simultaneous detection of common agents or pathogenic meningitis such as pneumococcus, meningococcus, listeria, and H. influenzae targeting conserved capsular gene BEX-A. Biofilm arrays and automated multiplex PCR, the respiratory panel can simultaneously detect 33 pathogens including Haemophilus influenzae. Antimicrobial susceptibility test AST is performed by disk diffusion method on Haemophilus test medium or chocolate agar, or by automated MIC detection method by microbot dilution, example Vitek. Treatment of Haemophilus influenzae infection: for invasive infections due to H. influenzae type B, cephalosporins such as ceftriaxone, cefotaxime for 1 to 2 weeks are the drug of choice. Alternatively, ampicillin plus chloramphenicol may be used. Non-typable strains of H. influenzae are often resistant to beta-lactams due to beta-lactamase production 20 to 35% of the strains, or rarely by expressing altered penicillin binding protein 3. Those strains are usually susceptible to quinolones, levofloxacin, and macrolides azithromycin. Prophylaxis: HIV conjugate vaccine, the polyribosyl ribitol phosphate PRP capsular antigen of H. influenzae type B is used for vaccination. As capsular antigens are poorly immunogenic to children, they are conjugated with adjuvants such as diphtheria toxoid, tetanus toxoid, and Neisseria meningitidis outer membrane proteins. In addition to eliciting protective antibody, the vaccine can also reduce the rate of pharyngeal colonization with HIV. Schedule: under National Immunization Program, HIV vaccine is given in combination with DPT hepatitis B pentavalent vaccine at 6, 10, and 14 weeks of birth. It is administered an IM route at anterolateral side of the mid-thigh. Protection: more than 95% of the infants develop protective antibody levels after receiving a primary series of 2 or 3 doses. The widespread use of conjugate vaccine has dramatically reduced the incidence of HIV disease in the developed countries. Chemoprophylaxis: oral rifampin is the drug of choice, indicated to household contacts or healthcare workers if 2 or more cases occur in hospital within 60 days. Now, this H. influenzae showing the growth around combined 10V disc, okay, but not around 10 and 5th disc. So this completes Haemophilus influenzae. Now let us start with staphylococcal pneumonia. Staphylococcus aureus causes pneumonia in selected clinical settings. Infant pneumonia: Staph aureus is a leading cause of pneumonia in newborns and infants. Presents with dyspnea, fever, and respiratory failure. Chest X-ray reveals characteristic pneumatocoel, shaggy, thin-walled cavities. Complications such as pneumothorax and empyema may be developed subsequently. VAP in adults: Staph aureus can cause pneumonia in hospitalized patients who are on mechanical ventilation, called ventilator-associated pneumonia (VAP). Patients who are nasal carriers are at risk to develop VAP. Post-viral CAP, community-acquired pneumonia due to Staph aureus, often follow viral infection, most commonly influenza. CA-MRSA, community-associated MRSA strains can be more virulent and can cause necrotizing pneumonia. Staphylococcus aureus mainly causes skin and soft tissue infections. Of course, we know that. Now, the gram-negative bacilli pneumonia. Gram-negative bacilli are increasingly associated to cause lobar pneumonia, particularly VAP, in the healthcare facility. Most of these agents are multidrug resistant (MDR) pathogens found in the hospital environment. Non-fermenters such as Pseudomonas aeruginosa, Acinetobacter, Burkholderia cepacia are the major cause of VAP. Enterobacteriaceae, various members of the family Enterobacteriaceae can be causing pneumonia, such as E. coli, Klebsiella pneumoniae, Enterobacter species such as, and Serratia marcescens. E. coli causes various other infections such as UTI, diarrhea, etc. Therefore, discussed elsewhere. Other agents are discussed here. For the members of Enterobacteriaceae, first, Klebsiella pneumoniae. Klebsiella are usually found as commensals in human intestine and saprophyte in soil. It has 3 species: Klebsiella pneumoniae, oxytoca, and granulomatous. Klebsiella pneumoniae further comprises of 3 subspecies: pneumoniae, ozyne, and rhinoscleromatous. Klebsiella pneumoniae subspecies pneumonia is the most pathogenic among all. It is responsible for severe lobar pneumonia, urinary tract infection, meningitis, neonates, septicemia, and pyogenic infections such as abscess and wound infections. It frequently colonizes the oropharynx of the hospitalized patients and is a common cause of nosocomial infections. Most of the hospital strains are multidrug resistant. Pneumonia tends to be destructive with the production of thick mucoid bracteate sputum. Sometimes the sputum has a thin and current jelly-like appearance. Some strains can really cause diarrhea and have been shown to produce an E. coli-like heat-stable enterotoxin. Hypervirulent strains of Klebsiella pneumoniae (HVKP). It is a strain of Klebsiella pneumoniae which has recently emerged as a pathogen of global concern. Hypervirulence HVKP is more virulent than classical Klebsiella pneumoniae, possesses several virulence factors such as Tedero4, increased capsule production, etc. Two capsular serotypes are there, K1 more common and K2. Manifestation HVKB is capable of causing various community acquired infections such as pyogenic liver abscess, most common, metastasize from liver to distant sites such as eye, lung, and CNS, can also cause primary extrahepatic infections including bacteremia, pneumonia, and soft tissue infections. HVKP strains are hypermucoid. A viscous string is formed when a loop is used to stretch the colonies on agar plate. This is the identification of the Klebsiella. A direct smear sputum of Klebsiella pneumoniae is shown in figure A, showing pus cells with gram-negative bacilli with a clear halo because of capsule. Klebsiella on McConkey agar is shown in figure B. Mucoid dome-shaped pink-colored lactose fermenting colonies are seen. And hypervirulent Klebsiella showing the string test positive is shown in figure C. Now comes the lab diagnosis. Klebsiella belongs to the family Enterobacteriaceae, similar to E. coli. Klebsiella species are also lactose fermenters. However, they differ in being non-motile and encapsulated, possess capsular polysaccharide. Specimens collected depend upon the site of infection, such as sputum, endotracheal aspirate, urine, blood, exudate specimen. Klebsiella pneumoniae shows the following properties: gram staining, short, plump, straightened, capsulated gram-negative rods. A culture on McConkey agar produces large dome-shaped mucoid due to capsule, sticky pink-colored lactose fermenting colonies. Identification of Klebsiella pneumoniae from the colonies is made either by automated identification system such as Martindorfer Vitek or by conventional biochemical test as described. Catalase positive and oxidase negative, ICUT test, indole test negative, citrate test positive, urease test positive, and TSI triple sugar iron test shows acid gas present, H2S absent. Treatment of Klebsiella infections Klebsiella is a global challenge owing to the marked drug resistance, which is much higher than that of E. coli. In healthcare facilities with high prevalence of MDR, Klebsiella pneumoniae, empirical treatment should be started with higher spectrum antimicrobial. The therapy can be tailored based upon the susceptibility report. Carbapenems, amikacin or beta lactamase inhibitors combination, BLBLIs such as piperacillin, tazobactam, or cefoperazone sublactam are usually the agents of choice for hospital-acquired MDR infections. Polymyxin or Glycycline are the next line of antimicrobials used for carbapenem resistant isolates. Resistance in Klebsiella pneumoniae is intrinsically resistant to ampicillin and ticarcillin. MDR majority of Klebsiella strains acquired in the hospitals are multidrug resistant, MDR resistant to cephalosporins, quinolones, cotrimoxazole, etc. However, it is if found susceptible, then these agents may be referred. ESBL in India 2019, 20 to 40 to 90% of the strains of Klebsiella pneumoniae are ESBL extended spectrum beta lactamases producers. Carbapenem resistance in India, carbapenem resistance in Klebsiella pneumoniae is reported to be around 28 to 56%, out of which 37% are cholesterol resistant. Carbapenem resistance is mainly due to the production of carbapenemases such as New Delhi beta lactamase (NBM) and Klebsiella pneumoniae carbapenemase (KPC). Other Klebsiella species cause infection of the other sites and therefore discussed elsewhere. Klebsiella pneumoniae species Ozani and Rhinoscleromatis are pathogens of nasal cavity, which we have already discussed. Now, the infections produced by Klebsiella oxytoca are similar to that of Klebsiella pneumoniae subspecies pneumoniae. Klebsiella granulomatis is the agent of a sexually transmitted disease called granuloma inguinale or adenovanosis. It is described in detail. Enterobacter species come second. Enterobacter species have become increasingly important nosocomial pathogens. Enterobacter aerogenes and Enterobacter cloacae are the most commonly isolated species from the clinical specimens. Enterobacter aerogenes has been recently renamed as Klebsiella aerogenes. They are widely distributed in water, sewage, soil, and feces of healthy person. They are opportunistic pathogens implicated in infected wounds, urinary and respiratory tract infection, pneumonia, and occasionally can cause septicemia and meningitis. Uh, Enterobacter sakazaki, recently named as Chronobacter sakazaki, can cause bacteremia and meningitis in neonates and is associated with consumption of powdered milk. Identification is made either by automated systems such as Marletov or Vitek or by conventional biochemical test. Most of the Enterobacter isolates are multidrug resistant and the guideline is for treatment is same as that for E. coli and Klebsiella. Enterobacter is intrinsically resistant to amoxicillin, clavulinate, and ampicillin sublactam. Third is Serratia marcescens. Serratia marcescens is the medically most important species. Human infection with other species is rare. Uh, it is characterized in two groups. Pigmented group, they produce characteristically red non-diffusible pigment called prodigiocin. They are saprophytes found in water, soil, and food. They may grow in sputum after collection and make the sputum red due to pigment production. This condition is known as pseudo-hemoptysis. Non-pigmented group of Serratia marcescens is being increasingly reported in various healthcare associated infections such as Lobar pneumonia, meningitis, endocarditis, septicemia, urinary and wound infections. Treatment for Serratia infections, the hospital strains are often multiple drug resistant, produce AMP-C beta lactamases. The guideline for treatment is same as that of E. coli and Klebsiella, except that it is intrinsically resistant to a number of antibiotics such as ampicillin, first and second generation cephalosporins, amoxicillin, clavulinate, ampicillin sublactam, nitrofurantoin, and polymyxins. In this figure, we can see the Serratia marcescens red colored colonies. Now coming to the last topic of the chapter, rare causes of the bacterial pneumonia, pulmonary anthrax. Pulmonary anthrax, also called as wool sorter's disease, is caused by Bacillus anthracis. It is a rare form of anthrax. Major form of anthrax is cutaneous anthrax, which we have already discussed. Transmission occurs by inhalation of the spores during exposure to contaminated animals' products, although also called as wool sorter's disease, as it is seen in workers of wool factory who acquire the infection by inhalation of the dust particle from infected wool. Bioterrorism. Pulmonary anthrax is the most common form of anthrax to be associated with bioterrorism. Incubation period is of 1 to 7 days, but up to 6 weeks or longer is reported. Hemorrhagic pneumonia presents initially with prodromal stage of fever, myalgia, and lethargy, followed by abrupt onset of hemorrhage, pneumonia leading to respiratory failure. Spread can spread by lymphatics or blood, leading to severe sepsis, hemorrhagic mediastinitis, and hemorrhagic meningitis. Chest X-ray shows mediastinal widening and or pleural effusions. Prognosis is usually poor, often fatal. Treatment. Pulmonary anthrax treatment comprises of antibiotic regime along with anthrax immunoglobulin. Antibiotic regime comprises of induction and maintenance therapy. Induction therapy, if meningitis suspected, ciprofloxacin plus meropenem, linezolid for given for 2 to 3 weeks. If meningitis is excluded, ciprofloxacin plus clindamycin or linezolid for 2 weeks is given. Maintenance therapy, oral ciprofloxacin or doxycycline is continued to complete 60 days course. Anthrax immunoglobulin, raxibacumab and oblitoximab are monoclonal antibodies that neutralize anthrax toxin with a protective antigen. Pneumonic plague. It is caused by zoonotic pathogen Yersinia pestis. Human plague occurs in three clinical forms: the bubonic, most common form, pneumonic, and the septicemic. Transmission, in contrast to bubonic plague, transmitted by rat flea. Pneumonic plague results from inhalation of the bacilline droplets expelled from another person or an animal with plague pneumonia. Incubation period is shorter than bubonic plague, about 1 to 3 days. Manifestation onset is sudden and characterized by fever, headache, and respiratory symptoms, productive cough or hemoptysis, dyspnea, and chest pain. Prognosis, though pneumonic plague is rare, less than 1%, it is highly infectious and highly fatal. Agent of bacterialism, aerosolized Yersinia pestis is a possible source of bacterialism attack, especially in non-endemic regions. Treatment gentamicin or streptomycin are given for treatment. Other bacterial agents that can occasionally cause pneumonia include nocardia. Lobar pneumonia is the most common pulmonary form, characterized by subacute onset cough with thick purulent sputum. It may rarely spread directly to adjacent tissues, leading to pericarditis, mediastinitis, laryngitis, tracheitis, and bronchitis. Actinomyces usually causes skin and soft tissue infection. Pulmonary actinomycosis is rare. Results from hematogenous spread, which is characterized by the formation of multiple nodules in the lungs. Streptococcus pyogenes, it is an upper respiratory tract pathogen, can occasionally cause pneumonia in previously healthy individuals. The common manifestations are chest pain due to pleural effusion, fever, chills, and dyspnea. Cough is present but less prominent. Streptococcus agalacti infants with early onset disease due to Streptococcus agalacti are bacteremic. One third to one half develop pneumonia and or respiratory distress syndrome. Streptococcus agalacti can also cause pneumonia in adults, though less common. Corynebacterium diphtheria is an upper respiratory tract pathogen where pneumonia is rare in complication. Non-typhoidal salmonella, they can cause lobar pneumonia and its complications such as lung abscess and empyema. The majority of cases occur in patients with lung cancer, structural lung disease, sickle cell disease, or glucocorticoid use. Aeromonas hydrophila is also a known etiological agent of lobar pneumonia. Rhodococcus equi is a gram-positive coccobacilli associated with necrotizing pneumonia and granulomatous infection, particularly in immunocompromised individuals. Moraxella catarrhalis is a harmless commensal of the upper respiratory tract and genital tract. Pathogenesis causes opportunistic lower respiratory tract infection, especially in adults with chronic obstructive airway disease. It has also been isolated in cases of otitis media, less common in meningitis, endocarditis, and sinusitis. Morphology: gram-negative diplococci 0.6 to 1 micrometer with oval, flattened adjacent sides. Culture grows on basal medium like nutrient agar. Identification is confirmed by automated systems such as MALDI-TOF or by various biochemical reactions. Some strains for M. catarrhalis secrete beta-lactamase which destroy penicillin, that makes beta-lactam antibiotics ineffective to the meningococci and other penicillin-sensitive bacteria of the respiratory tract. Moraxella has other species M. lacinata which causes angular conjunctivitis. So this completes the chapter. Now come to expected questions. Alisha, 4-year-old girl from Bhubaneswar, was brought to an emergency department by parents due to acute onset of fever, productive cough and dyspnea for past 2 days. Physical examination revealed dull note on percussion. Direct examination of the sputum revealed plenty of pus cells and gram-positive lanceolate shaped diplococci surrounded by halo. Of course, this is a case of Streptococcus pneumonia. All about the diagnosis, etiological agent, factor, pathogenesis, and management can be written. Short notes on pneumococcal vaccine, pulmonary anthrax, hypervirulent Klebsiella can be written. 2-year orphan boy presented with fever, cough, and dyspnea for 4 days. Sputum culture revealed colonies were Staph aureus streak line in blood agar. What is the radiological diagnosis and prevention? Agent is Haemophilus influenzae. Prevention and all we can write by vaccination and stuff. Now, which of the following agent of meningitis can grow on chocolate agar but not on blood agar? It is Haemophilus influenzae. Haemophilus influenzae grows on all of the media except chocolate agar, filter agar, nutrient agar, blood agar with Staph aureus streak line is in nutrient agar. Polyribosyl ribulose phosphate PRP antigen is present in the capsule of influenza type B. Next to HIB, which strains are the most common group of Haemophilus influenzae surrounded clinically? It is non-typable strains. Okay, now the wool sorter disease is caused by, of course, caused by Bacillus anthracis. So this completes our chapter. Next we'll be starting with atypical pneumonia. So like, share, subscribe. Thanks for watching.